Hi there, it's the 24th of March 2020 and my name is Gerard Greene and I'd like to welcome you to this Coventry University Master's session on the pelvic girdle linking hip, lumbar spine and pelvis. I hope this time finds you well as we are in the midst of a lot of uncertainty with the coronavirus, and I'm somewhat saddened that I can't present to you in person, but I hope that you will find the webinar a really good learning experience. So what we're going to really look at is the pelvic girdle and its relevance to patients with maybe lumbar spine, pelvic and hip dysfunction, and also trying to work out, is there a pelvic girdle and also pelvic floor component with these patients. And my interest in this comes from the work that I do in women's health or female pelvic health, and also the work that I do in male pelvic health. And so as my first exercise I'd want you to do is to work out what the relevance of the balls are. So if you think, and also what does 1 and 3 mean? So in terms of women's health, what does 1 and 3 mean? So the balls relates to testicles, so that's men's health, and 1 and 3 is the really high incidence of stress and urinary incontinence in females. I think it's really important, particularly at this time when a lot of us will be practicing kind of new guidelines in social isolation and social distancing, that we really keep in contact through other mediums such as online. So for those of you who are on Twitter, that's my Twitter feed at Gerard Greene PHY, and also our undergraduates have built a really powerful Twitter feed at CU Physio. We also have 2 amazing groups on Facebook. I think it's safe to say that Facebook is a very supportive community, particularly in male and female pelvic health. So we've got the Men's Health Physiotherapy group that was developed by my good friend and colleague, Dr. Joanne Millius from Perth in Western Australia. And then we've got the Women's Health Physiotherapy group that was developed by myself and one of my colleagues. And they have big numbers of people who also discuss a lot of pelvic girdle dysfunction, a lot of musculoskeletal pelvic dysfunction. And in the last couple of years, we've seen a real growth in the Instagram community. And my Instagram feed is Harborne PT. What I'd like you to do first is really to look at some pelvic anatomy. So if you find Anatomy Zone on YouTube, it's a really brilliant resource and it's free to access. And if you click on pelvic floor anatomy, there are about 3 really brilliant, quite visual clips on the pelvic floor. Pelvic floor is quite a complex structure, and sometimes I think when I did it first, I think the more I read about the pelvic floor, the more confused I got. So really good way of learning this is obviously to do some reading about it, but also I think the anatomy clips on YouTube are very powerful. It's also important that we know about the pudendal nerve. So the pudendal nerve comes from S234, and the pudendal nerve is something we will visit later on, but it's really important for motor supply to the pelvic floor, and also sensory supply to that rectal area, to the perineum, which is the soft area underneath, female and male genitalia. It's also important for supplying some of the sphincters. These are the voluntary sphincters that we can contract and relax around the bowel and around the urethra, or the tube from the bladder. I think when I learned anatomy, and we did a lot of cadaveric anatomy, we did probably 1 year of lower quadrant anatomy, and we didn't really touch on the pelvic floor. We didn't touch on the pudendal nerve. And I think even now in most courses it would be quite rare for students to cover the pelvic floor or pudendal nerve. Obturator internus. I think my knowledge of obturator internus was that there are 6 deep lateral rotators of the hip, and obturator internus is one of them. But we never really went into any detail as to what its attachments were, that it comes from within the pelvis to emerge externally, to attach to that kind of greater trochanter, but also that it's a physical connection between that internal pelvic floor and the hip joint. And it's also got a connection, quite a close connection, with the pudendal nerve. My cat has just come to join me as well, so we may hear the cat in a minute. So there's also some nice clips on Anatomy Zone on the pudendal nerve and also obturator internus. Obturator internus is particularly important for this lecture and topic because we will commonly see patients with pelvic dysfunction who have a hip component, and we will see patients with hip dysfunction who have a pelvic floor component. And that link is really through the obturator internus. I'd like you to think to yourself, maybe jot down some notes, is, well, what have you heard about the pudendal nerve? You know, is this something that was covered in maybe your undergraduate training, maybe some postgraduate training? I know a lot of you work in with a lot of lower limb, lower quadrant patients, a lot of spinal patients. So what do you know about the pudendal nerve? What do you think its relevance for your work is? Also, what's the relevance of the pelvic floor to you? So how do you think the pelvic floor is relevant to some of the female lumbar spine patients you see? Maybe some of the female pelvic girdle patients you see? Maybe some of the female hip patients you see? And the same for the male patients. And also, if you see younger patients, maybe you see sporting adolescents and males, what's the relevance of the pelvic floor to those patients? What's the nerve supply to the pelvis? So if someone were to say to you, maybe in a Viva form, well, can you talk to me about the nerve supply of the pelvis, the nerve supply of the groin, the anterior aspect of the hip, the posterior gluteal area, the perineum, the genital area? What's the nerve supply to that area? And the nerve supply to that area is quite complex, which we'll come to in a few moments. There are multiple tests of the pelvic girdle. We have movement tests, probably aren't done as much now. We have positional tests, which probably aren't done as much now. We have pain provocation tests, which probably are done a lot now. So what tests have you come across? Maybe on postgraduate courses, or you've read up, or that you've just intuitively learned. So what tests would you currently do to see, does someone have a pelvic girdle dysfunction? I'd like to express my thanks to my good friend and colleague Peter Dornan. Peter is known as the godfather of male pelvic health, the godfather without all the dead bodies and horse's head. Peter's done some really exceptional work on really mobilizing physios to get involved in pelvic health, and especially in pelvic pain. And Peter has done a really nice map of the pudendal nerve, and it really, and you can you'll see this a bit clearer when you on your own recording, but the pudendal nerve comes from S2, 3, 4. It's got several branches. It's got a muscular branch, and that supplies really a lot of the pelvic floor muscles. The pelvic floor that wraps around the rectum, which is the external anal sphincter, and the part of the pelvic floor that wraps around the urethra, which is the external urethral sphincter. So it can be involved in conditions where there's pain after urination, pain after bowel movements, erectile dysfunction, premature ejaculation, pain during sex. We also have the dorsal nerve of the penis in males and the clitoral nerve in females. So that's the sensory supply to that external genital area. So in patients who are getting pain in that area or changes in sensation, pins and needles, maybe hypersensitivity, maybe hyposensitivity, maybe changes in temperature, maybe changes in how the genitalia look, a little bit like complex regional pain syndrome would affect how a foot and ankle looks or a hand. The pudendal nerve can be involved. We also then have the perineal nerve. So that supplies the perineum. That's particularly important maybe in patients who've got symptoms on sitting, driving, can't sit on a hard surface, maybe have some or complaining of coccyx pain, maybe complaining if they feel there's something hard inside the perineum. Then we have the rectal nerve, which supplies that external anal sphincter and also the sensation around the rectum. I'd like to also thank a clinician in LA, Jeff Gibson, who very kindly gave me permission to use these two pictures. This shows the pelvic floor, and if you put Jeff into Google, so it's malepelvicfloor.com, there's some really nice listings of what these individual muscles are. I think what I would do is have a look at Jeff's images in conjunction with Anatomy Zone. But really, at a very basic level, the pelvic floor is a group of muscles that attaches from the back of the pubic bone to the coccyx, spans out laterally to attach to the fascia and bony structure of the pelvis, and then has special thickenings around the urethra, the rectum, and the vagina in females. It's also got more superficial muscles, the ischio and bulbocavernosus, which are important for sexual function in male and females. And then it's got a thickening around the urethra, which is the external urethral sphincter. So if I'm here doing this webinar and I need the loo, I can kind of contract those just to kind of hold on. Then it's also got a thickening around the rectum, which is the external anal sphincter. So if I need a bowel movement, but I'm not somewhere I can do a bowel movement, I can contract the back passage, which will contract that anal sphincter. The nerve supply of the pelvis is quite complex. We've got the pudendal nerve, which supplies the rectum, perineum, soft part underneath, genital area. Then on that anterior groin, we've got the ilioinguinal nerve, genitofemoral going from medial to lateral, and then the lateral cutaneous nerve of the thigh, and also laterally the iliohypogastric. The sciatic nerve doesn't contribute much sensory innervation, but it does pass through that posterior hip region, particularly in relation to piriformis. But we've got the cluneal nerves, which are nerves from the upper lumbar spine, which are sensory nerves to that buttock area. It's also important to note that we've got somatic patterns of referral. So probably from David's lecture last week, for those of you who were there in person, the sacroiliac joint can refer pain into the pelvis, as can the lumbar spine, and also can some of the muscles. And for the muscular referral, I'd probably recommend you to Jan Dummerhol's work on this is kind of myogenic patterns of referred pain. where you've got areas of hypersensitivity within the muscle, I think what are traditionally called in the past trigger points, where you can get referral down into the pelvis, and they can be maybe from the adductor group, from the quadratus lumborum, from some of the deep lateral hip rotators. You can get referral into those areas. A little bit like we can get referral maybe from the upper traps or sternocleidomastoid into the occipital or frontal area of the skull. So what does a typical female pelvic pain patient look like? So what we've done in the clinic, and I'll show you the blog later, so we've got patients really to write about their experiences as to what pelvic pain was to them. So a typical female pelvic pain patient will present with maybe pain in the perineum, maybe some genital pain. They may also have low back pain, maybe referred groin pain. They may have urinary frequency. They may have pain on bowel movements. And they also may have pain with intimacy. A typical male pelvic pain patient, so they may come in with some pain post-ejaculation or pain on sexual activity. They may be having scrotal or penile pain. They may be getting maybe some penile changes in sensation. They may also be getting pain in the perineum, which is maybe preventing them from sitting or limiting them from sitting, but also maybe getting hip and lumbar spine pain. So what's the typical male athletic pelvic pain patient? So this is Constantinos, who is one of my brilliant physios. So this typically is maybe someone who's doing maybe a lot of heavy weightlifting, and maybe they start off with a little bit of pubic symphysis discomfort, a bit of lower abdominal discomfort, a bit of groin pain, maybe back pain. But then that progresses and they suddenly feel that they're getting pain maybe more localized to the pubic symphysis, more localized to the perineum. But they then may notice that they're getting maybe some rectal pain, or maybe some very subtle erectile changes. So instead of them getting more in erections every morning, they're fading a little bit. Or it may be that their erection is no longer as full as possible, or they might be getting a little bit of ejaculatory pain. They may also notice that they're starting to get some urinary frequency. So instead of urinating every maybe 2 to 3 hours, they're having to urinate every hour. And then typically a lot of these patients feel that, well, I need to strengthen to do more. So they start to do pelvic floor strengthening exercises, which makes things worse. I also see a lot of cycling patients, and there's a really nice cycling blog that I'll highlight in a moment. And these are patients who maybe get pins and needles, sensory changes in the perineum, penile area. They might be getting, it may have started off with low back pain on cycling, but has really evolved to get some groin pain, but then also to getting maybe some very mild, subtle erectile changes, some penile symptoms. So what is the typical female athletic pelvic pain patient? This is very variable as well. I suppose the typical one we see is the maybe very fit, healthy, physically active female who is getting some urinary frequency, maybe some very subtle loss in control of wind. It's a big symptom, particularly on strenuous exercise. These are like the dancers, trampolinists, tumblers, gymnasts. They may also be getting some pain on intimacy, so that pain on sexual activity, maybe pain on using a tampon. And they may also start to feel that they're getting some maybe pain on bowel movements. We also have another big group of this, and these are the patients who you will be seeing in clinic or your hospitals. These are the postnatal patients. So this might be a lady who's going back to running, going back to spinning, going back to Pilates, going back to yoga, where they're starting to get maybe low back pain or abdominal pain or hip pain. And what they may have is they may have some maybe stiffness in that lumbar spine or hips. They may have a rectus diastasis where they may have an increased tummy gap. They may have some pelvic floor weakness. So that's another very common kind of sporting pelvic health patient group. So what's pelvic girdle pain? This tends to be pain that's experienced kind of between the posterior iliac crest, gluteal fold, particularly around that sacroiliac joint. May have some distal referral, but you may also get symptoms in the pubic symphysis. And I suppose the big group we see is relation to pregnancy, postnatal, or exercise or activity. So I think I wouldn't just look at pelvic girdle pain in relation to pregnancy. I would also look at it in relation to those sporting patients, those patients where they're doing a lot of hip movement, like football, running, cycling, dance, gymnastics. So anything we get a lot of hip, pelvic girdle, spine movement, you can get pelvic girdle pain. This is really in relation to the that pregnancy population. So as we can see there, it's very common. And also some women, new mums or second or third time mums, will continue to get pelvic girdle pain postnatally or may develop it. So we really want to do some evidence-based tests, both with the postnatal population, pregnancy population, but also those patients who have pelvic girdle pain unrelated to pregnancy. The tests that we tend to do a lot of are the pelvic pain provocation tests. So there's some really nice work done by van der Wolf, Fleming, which have looked at the diagnostic validity of these, which tends to be high, and the reliability. So these are a combination of tests such as Faber's, where we flex, abduct, externally rotate the hip. Gainsland, where you flex one hip, extend the other hip. Thigh thrust, or the P4 test, where you flex the hip, slightly adducted, apply some compression down through the hip. The sacral thrust, that's really where you just do a PA pressure on the sacrum. And then compression, is where you put the patient in sideline, apply a degree of compression through the ilium. You're really looking for 3 of these or more to be positive. Positive means that you're reproducing the patient's symptoms. So I think that the really good tests to do are the pelvic pain provocation tests. These are useful if you have a patient maybe with low back pain, but you're thinking, do they have a pelvic girdle component? You've got a patient with a hip presentation, so they're quite good to rule in or out that pelvic girdle. I think where they are particularly useful is where we see a lot of patients come in and they say, well, my pelvis is out of place, or my pelvis is in the wrong position, or I saw someone and they told me my pelvis is out. These tests, if they're negative, can reassure these patients your pelvic girdle is okay. These are reliable, valid tests. They're negative. It's unlikely your pelvic girdle is affected. So also some nice work done by some Norwegian researchers and also Fleming and the Caribou group in Norway, done on the active straight leg raise. So this is where you get a patient in lying, get them to lift the leg up to about 20 centimeters, and you're really asking them how easy or difficult it is to do that. You can grade that 0 to 5, but I think clinically what I say to the patient is it easy or difficult? And it should be easy, it should be no effort. In the pelvic girdle patient, it can be difficult to do. We also ask them, is it painful to do? And we also look at the quality of movement. And if you put those tests into YouTube, those tests will also come up. If the straight leg raise is positive meaning I find it difficult to do, or it's painful, or the quality of movement is poor, what you can then do is apply some compression to the pelvic girdle, either side of the ilium, and retest and see is it easier. Why is the test positive in the first place? It may be that those muscles, such as the abdominals, pelvic floor, posterior muscles, are not functioning well to provide support to that pelvis and lumbar spine to then allow that hip to move. We also look at Trendelenburg. Trendelenburg and also single knee bend, really to see what's the general control, symmetry, quality of movement of that pelvis like. And we also look at hip movement. Hip abduction, adduction. This is important because patients with particularly pubic symphysis dysfunction do not like hip abduction, purely for the mechanical reason that when you abduct that hip, you're applying a stretch to the adductor group, and that can be provocative. So it can be a pain provocation test. We also do a lot of palpation of the pubic symphysis. This is very straightforward to do because it's a very superficial structure. And what you tend to do is put your hand, fingers pointing towards the head on the lower abdomen. So you're going to palpate the pubic symphysis with your thenar and hypothenar eminence. You explain to the patient what you're going to do, gradually move your hand distally so you get the pubic symphysis, and then also when you move left and right, you get the right and left pubic tubercle. I say to patients, well, I kind of initially palpate their tibial tuberosity and say, this is what it should feel like, i.e. very little, shouldn't be tender, shouldn't be painful. What you get in the pelvic girdle pain patients is, or pelvic pain patients, or pubic symphysis patients, it's painful. It may be painful locally, or it may refer into the perineum, into the groin, but there's a definitely degree of pain. And I would probably practice this maybe on yourselves or someone at home, just that you get used to the kind of communication with the patient. So who's at risk postnatally? This links into really, there's some really nice work done by Paul Hodges. So if you Google Paul Hodges Pelvic Girdle Pain podcast, there's a really nice one, and he talks about, which is also relevant for a lot of the other pelvic girdle patients. There is a big relationship with yellow flags or kind of negative prognostic factors. Also, the patients who maybe previously had low back pain or had more severe pelvic girdle pain during pregnancy. Those who had previous hip, spinal, musculoskeletal problems. So basically, sometimes the patients who did quite poorly in the antenatal phase may not do so well postnatally. But these are patients that we can see and help. I think currently, particularly with social media, there is this belief that postnatally, within 6 weeks, women will get their kind of pre-pregnancy figure back, a bit like Beyonce. Here we have Beyonce with her twins, and we had twins in our house 14 years ago, and there were definitely less flowers than this. Here we have Princess Catherine. This was just when she was leaving the hospital. And this was quite a powerful picture because it just demonstrates that, normally postnatally, the bump is still there. That uterus has to still contract. So rather than her wearing something to cover that up, or she was happy to say, well, this is normal. And these ladies to the right, this is normal. You get a degree of quite marked change to that abdominal architecture and muscular and linea alba. So what is a rectus diastasis? A rectus diastasis is where you're getting widening of the linea alba. So what I would do now is just palpate your rectus abdominis, palpate the lateral border of that and the medial border of that. Between both medial borders, you have the linea alba, and in males, it tends to be quite narrow, probably about 6-7 millimeters. Although sometimes if people have trained a lot of abdominal work, they can get a diastasis where it's maybe up to about 2 fingers. In females, in nulliparous women who haven't been through pregnancy, it tends to be around 7-8 millimeters. And the average postnatally is up to about 20 millimeters or 2 centimeters or 2 finger widths. So anything wider than 2 fingers is termed a diastasis. And really, the women that you're seeing who've been through pregnancy, so they may be coming to you with low back pain, and you might think, well, but they had a baby, their kids are toddlers, or their kids have just started school. It's important that you check, do they have a diastasis? Where the women coming into you, they've gone back running and they've come in with knee or hip pain. And their child was born 3-4 years ago. You still need to check what's that diastasis. So I think a really important thing to take out of this lecture is that once postnatal, always postnatal. If you're seeing female patients who've had children, which you will, you have to check that diastasis. Even if they're not mentioning anything that happened in pregnancy postnatal, that doesn't matter. You have to check the diastasis. And what you do is you map out where the rectus diastasis is, that medial and lateral borders. You've got to sink in through the adipose tissue. A lot of people measure between the adipose tissue and they'll get a huge measurement. You go through that. We are physiotherapists. We are skilled at palpation. You go through that. You find that defined medial edge, other medial edge. You press in. It should feel lots of resistance. There should not be much depth there. It should feel like you're pressing on something solid. You get them to lift their head up and you see what the distance is. Most women pre-pregnancy or haven't been through pregnancy, it will be less than a finger. A diastasis is termed greater than 2 fingers. So you may see women with a 3-finger, 4-finger diastasis, but it's really important to check. And the same again, practice on yourself, practice on some family members at home. You won't be practicing on friends at the minute because we're social distancing. And Carrie Bow's work is really seminal on this. So she's done some really nice work on what the normal distances are and how to define it, and prevalence. And as we can see, postpartum, it's quite normal postpartum. Probably 1/3 at a year. We also have some nice work done from Moto et al. 2014, looking at the incidence. I think this is important because it's important to say to women may be concerned because they have a 1-finger gap or that they have up to a 2-finger gap, but that's okay. We know that is normal. Probably the ones that we're concerned with are greater than 2 fingers. However, to add complexity, Someone may have a 2-3 finger gap, but if their abdominals are strong enough, working well, they will compensate for that. So these are the women where at rest in lying, they have a 3 finger gap, and you think, well, that's wide. But then you get them to contract their deep abdominals, pelvic floor, you feel tension in that. You get them to do a head lift, and it feels really solid. So they have like a diastasis that doesn't really need any intervention. The women who do need an intervention or treatment management are the women where they lift up and the midline, the linea alba, is doming or bulging out. And a lot of these papers are available via Google Scholar, or if anyone needs them, please don't hesitate to email me. So what's the relationship between a diastasis and pelvic floor dysfunction? It's not clear. Some early studies really highlight that if you have a diastasis, more likely to maybe have stress incontinence, fecal incontinence, pelvic organ prolapse. Probably less emphasis on that now because there hasn't been any maybe further supporting work to highlight that close linkage. Some work done by the Caribou group in Norway. So women with a diastasis didn't have any more incidence of pelvic girdle, of lumbopelvic pain. I think what it's important, and I suppose what we do in clinic, is we assess each woman as an individual. We say to them, are you getting urinary symptoms, bowel, sexual health symptoms, rather than thinking everyone with a diastasis has these problems or everyone doesn't. So let's say a runner comes in to see you with hip pain and you note that they have a 3-year-old or they've brought a 5-year-old with them into clinic, which always is good, but that either, we see a lot of kids in the clinic and it either goes one of two ways. It either goes very well or it's a bit chaotic. But we love our kids and we see lots of mums who are happy to have them in the clinic. What could you ask these women? So this is a woman you're seeing for hip pain and you're thinking like, oh, I don't really know much about this. So what you could ask them is, are you experiencing abdominal weakness? Are you getting any doming or bulging of the abdomen, especially when you come up from lying, or when you do any heavy work or lifting, or maybe when you do some lunging or burpees or squatting? Are you getting abdominal pain or pubic symphysis pain? Are you aware of a gap in your tummy? Have they had this before? And if they are aware, have they looked at how many fingers they can get into the gap? Is it worse than exercise? Is it getting better or worse? And what are they doing for it? So some people, a lot of women will think, well, I need to strengthen it. So they'll start to do lots of abdominal work, planking, heavy lifting. But it may be that that's making things worse. So let's say you have a patient who they've come to see you with back pain and they've come to see you because you've seen them in the past for back pain and they think, well, I've seen so-and-so before and I'm trying to get back to running, but I can't. So before they get back to sport, so let's say you've sorted their back pain out. So what should these women be able to do before they get back to sport? The active straight leg raise should be easy to do. The stork test, I don't mean the positional test. What I mean is in standing, they can flex that knee to chest with no symptoms, good control, good quality of movement. They can do a single knee bend well. They can hop. They can do knees to chest. They can jump. They can run on a treadmill. And you might not have a treadmill, so you could say to them, well, going to get you to do some walk run. Is that okay? So as you'll see, this looks very like normal musculoskeletal physio. So if we had a knee patient who's had maybe an MCL injury or patellofemoral pain, we would say to them, okay, before you go back running, we probably want good range of movement, good strength in your quads and hamstrings. We want you to be able to lunge, squat, jump, do some proprioceptive exercises. So it's really the same. So what's pelvic pain? So pelvic girdle pain is more musculoskeletal, to do with the joints, ligaments, tissues around the pelvic girdle. Pelvic pain, so this is where someone is getting pain in that pelvic area, but they're also, this is the key thing, they're also getting urinary symptoms, bowel symptoms, or sexual health symptoms. So the big difference between pelvic pain and pelvic girdle pain is pelvic pain has urinary, bowel, sexual symptoms, and pelvic pain has symptoms into the rectum, perineum, genital area, whereas pelvic girdle pain is more around sacrum, posterior buttock area, pubic symptoms. And also in pelvic pain, you tend to have, with a lot of patients, but less so the sporting ones probably, you've got a lot of stress, anxiety, mood change, catastrophizing, fear avoidance. And these patients have usually been through extensive urological, colorectal, sexual health, and often spinal screening. So commonly they'll have seen 3 or 4 specialists. So does my musculoskeletal or sports patient have pelvic pain or pelvic floor dysfunction? Are they getting symptoms in the perineum, vagina, rectum, or those areas? Are they getting urinary symptoms? Are they getting rectal symptoms, sexual health symptoms? If I ask a patient, are they getting urinary symptoms, a lot of them will say no. And the reason they say no is because those symptoms have become normalized. So it's normal for them to go to the loo every hour. It's normal for them to have to wait for 5-10 seconds to urinate. It's normal for them to be constipated. It's normal for that woman, or she feels it's normal, to have pain on either masturbation or sexual penetrative intercourse with someone else. So we tend to dig a little bit deeper as to what's happening. They may be getting some erectile dysfunction, some pain and sex, and often, which is relevant for you guys seeing lots of sporty patients, it's often aggravated by abdominal work and strengthening. So they say, well, my back pain started when I was doing lots of heavy lifting. And sitting is also a big aggravating factor. Not in everybody, but a lot. Also common is urinary pain or frequency. Maybe mild urinary incontinence. Bit of droplets. Also common is lack of control of wind. A lot of rectal pain post-bowel movement. The feeling that there's a golf ball in the rectum and they're sitting on a golf ball or tennis ball. Or that they're sitting on a block of wood. Ejaculatory pain, weak or erection, premature ejaculation. And pain on sex, that's a big one. What happens in the penis? It can be painful. It may be one side, painful on one side, maybe hypersensitive to touch. Maybe hyposensitive. Sometimes men complain of feeling dead, like a piece of meat. They may be getting pins and needles. They may be getting a weaker erection. They may be getting ejaculatory pain. In terms of vaginal symptoms, pain in intercourse, pain on tampons, pain in using a vibrator or dildo, There may be changes in sensitivity. It may become hypersensitive or hyposensitive. There may be a feeling of internal tightness. There may be an inability to orgasm. Or there may be dryness, which is moving towards kind of vaginal atrophy. The big bowel symptoms. So what might you expect? So let's say you have a female high-level footballer, or you have a crossfitter, or you have a female triathlete. So what bowel symptoms might you expect? Maybe even write down one or two. Probably the common ones are lack of control of wind, little bit of leakage, tiny bits of leakage, kind of almost soiling, an inability to clean fully. This is a big one. Someone does a bowel movement and they have this inability to get clean, almost that there's almost a little bit left. Constipation. Urgency. I have to do a bowel movement and I have to do it now. So how do you ask those questions? People always say, well, how do I ask those questions? So a really good thing is to use the questionnaire. So if you put into Google the NIH, or National Institute of Health, male and female questionnaire, they are really useful. You maybe hand them to the patient and say, well, just fill this in, and you can talk about those. There's also the Stanford Pelvic Pain Questionnaire. And there's also the International Index of Erectile Dysfunction Questionnaire. And we also have Jane Chambers, who's an Australian researcher. So we have our Female Pelvic Pain Questionnaire. So those questionnaires are useful. Female Pelvic Pain Questionnaire, International Index of Erectile Dysfunction, Stanford Pelvic Pain, you can do that male and female, NIH, male and female. So I would encourage you, get on Google, look at those four. It is a huge relief to either your triathlete, your runner, your mum, not your mum, but maybe a mum. But you don't ask your mum about these things. That man who's getting hip back pain, but he says that, well, something else is going on. It's a huge relief to be asked about those. So this is the Jane Chambers work from Australia. This is a female pelvic pain. Are they getting pain on levels of intimacy or sexual activity? Is this woman getting stomach or intestinal symptoms? Mood changes? Symptoms using tampons? Symptoms when sitting for longer than 20 minutes? Or any symptoms in the pelvis? So a prolapse is another condition that you may be seeing patients with, but they may not mention that to you. This is particularly relevant for sporting patients, sporting females, either postnatal, especially if someone's had a very traumatic birth, someone's had a forceps delivery, a prolonged labour, constipation, or someone maybe who's postmenopausal. And a prolapse is really where the position of the internal pelvic organs has changed. So there is movement of the bladder into the vagina, movement of the bowel into the vagina, or descent of the uterus, or descent of the vagina. So it's important to ask the patient, do they know what a prolapse is? Do they feel pressure? So you're getting someone who's running and they're saying, well, I'm getting a lot of aching underneath. So you could say to them, well, do you feel some pressure in your vagina? Do you feel something bulging? Is there something coming out? I think by that stage they may have gone to their GP. And also, do you feel pressure in your vagina when you do strenuous activity or exercise? Has this gotten worse? And what you would then do is work out, well, who can look after these women in my local area or my team who's got expertise in women's health? So what is urinary incontinence? So this is involuntary leakage of urine. And it's good to say, if you say to a lot of women, are you getting urinary symptoms? They will say no, even if they are. Any leakage is urinary incontinence. Any leakage is abnormal and should be treated. And is that related to exercise activity, strenuous activity? Is it sports related? Also, are they going to the toilet frequently? They should be able to hold 2 to 3 hours. These women may be going every half an hour, every hour. Or they may be jicking, which is they're going just in case. We've talked a bit about the bowel movement, so pain, type of stool. You probably won't use the Bristol stool chart, but you can Google it. It will kind of amuse you for a couple of minutes. So we then want to get back to pelvic floor function. So is this patient's pelvic floor normal, underactive, or overactive? This is kind of less straightforward than it seems. Now this is a general overview, but we assess each patient individually. Generally, but not always, you can get underactivity postnatally, postmenopausally. But there are obvious exceptions to that, but general rule of thumb. In pelvic pain, it tends to be overactive. It's working too much. And that leads to pain, that can lead to spasm, that can lead to weakness or poor function. It's a bit like if your calf is in spasm, it's not going to work very well, so it will test weak, but it's weak due to being overactive. In the athlete, probably more particularly female or male here, there tends to be overactivity. And then if you've seen men post-prostatectomy, because you might be seeing these men for hip replacements, knee replacements, maybe another musculoskeletal problem, that their pelvic floor needs to work harder to compensate for the surgery. How do I know if it's overactive? Because if it's overactive, they shouldn't be doing strengthening. If someone has overactivity of the pelvic floor, they shouldn't be doing strengthening. They should be doing relaxation work. So they may be getting symptoms of pelvic floor dysfunction, urinary symptoms, bowel, sexual health, genital pain, perineal pain, or other symptoms in those areas, rectal pain. When we examine them, we may examine them through ultrasound imaging, which you will like because it's non-invasive, a lot of it's transabdominal, or what the male and female pelvic health physios do is they assess these men and women internally. Usually vaginally in females, sometimes rectally in males. You get a lot of distress, a lot of stress, anxiety, catastrophizing. And I like this, it's the International Continence Society. So the pelvic floor muscles don't relax when or it may be contracted when they shouldn't be. This is underactivity. This is what you will commonly see postnatally, postmenopausally. But, it's not that black and white straightforward. So these were the muscles, they're not voluntarily contracting well. Those women may be getting urinary incontinence, fecal or anal incontinence, leakage, soiling, pelvic organ prolapse. And these have underactivity. So this is weakness. I would start with Peter Dornan's book, because Peter came from an elite sport background in Australia. So his work is very we can connect, musculoskeletal physio, sports physios can kind of connect with Peter's work. Kind of makes sense to them. No internal work, very kind of musculoskeletal type. My colleague Ruth Jones, Dr. Ruth Jones, who used to work in Southampton, was also a musculoskeletal sports physio. So her pelvic pain work has got a strong musculoskeletal foundation. This is a seminal pelvic floor book by Professor Carrie Bow. So I think the three of these probably start with Peter, Ruth, Carrie Bow. So how does all this happen? How does pelvic pain happen? So it may be that there was a previous low back pain, pelvic girdle, sacroiliac joint problem, pelvic dysfunction. Some really nice work done by Paul Hodges and Ryan Stafford in Australia that there are quite a high incidence of pelvic floor dysfunction following low back pain. So in patients with low back pain, you really should be asking some of these questions. Maybe there was some trauma. A lot of the younger guys, younger females, or males and females who do a lot of heavy abdominal training, lifting, weightlifting, have an increased incidence. It may be that there's some underlying stress or anxiety that precipitated the onset of this. They may actually have had a recurrent urinary tract infections or a urinary or rectal condition or surgery in those areas that led to the onset of this. There may have been some local trauma to that area, or there may have been some surgical procedures. All of the research, to the best of my knowledge, has been done on female athletes, and the incidence is high. Probably about 50% plus of female athletes will get pelvic floor dysfunction. So it's very high. There isn't really any research on men. I think what we tend to see clinically in the men is the main symptom of pain or erectile dysfunction, subtle erectile dysfunction, ejaculatory pain, urinary frequency. But there is a lack of research here. I would really encourage you to look at the questionnaires. They're very useful. That's the NIH questionnaire, Stanford Pelvic Pain, International Index of Erectile Dysfunction, and the Female Pelvic Pain Inventory Questionnaire. Because I think by reading those, it really gives you a really clear insight into what questions you can ask these men and women. So the frogs were done for a promotional piece myself and Joe did for the South African Physiotherapy Society. So this highlights that men, they hear no evil, see no evil, speak no evil, i.e. they don't talk about this, they don't tell anyone. So we don't really know the incidence. But it's the most common urological condition in younger men, third over 50. This condition used to be called prostatitis, but now it's more a subclassification of prostatitis where there isn't, probably in about 95% of men, there isn't a prostate component. But we do know that men continue to be symptomatic well after diagnosis. And it's almost impossible for them to find help. So there's a real lack of research. Men do not talk about this. Your premiership footballers, your rugby players, your cyclists, your triathletes, your your crossfitters, your weightlifters, they're not going to say to their someone they're training with, well, I've got some subtle erectile dysfunction, or I get pain when I ejaculate, or I'm having to go to the loo every hour, or I can't control wind, or I'm getting scrotal pain. Men don't talk about this. So this is what we look for in these sporty men. Are they getting urinary pain or frequency? Are they getting rectal pain? Do they feel like they're sitting on a block of wood, tennis ball? Ejaculatory pain, weak or erection? I'm hoping here that these two frogs live together, because this does not look like social distancing to me. This is not 2 meters. And in the men, as we've talked about, excuse me, these are the big areas: testicles, pubic area, penis. We're looking for genital pain. With these sporty musculoskeletal men also who come in, we discuss penile health. Pain, hypersensitivity to touch, pins and needles. So these men can still get an erection. They can still masturbate. They can still have penetrative sex. They can still ejaculate. But it's different. It's different. It's maybe weaker. It's an 80-90% erection. It takes more stimulation to get erect. It takes more stimulation to stay erect. There also may be fear avoidance. So fear avoidance is something we see in low back pain, degenerative knee conditions. So you also get fear avoidance of masturbation, fear avoidance of intimacy. This is a big thing: ejaculatory, post-ejaculatory pain. So these men get a flare up in their symptoms post-ejaculation. And a bit like the complex regional pains patients, they get structural tissue changes. That penis is a bit retracted. It may change pigmentation or color. There are vascular changes. The quality of the tissue changes also. So what's going on with the pelvic floor in these male and female pelvic pain patients? There is overactivity. What we also see in other chronic pain conditions, there is allodynia, secondary hyperalgesia, and also lack of good normal quality motor muscle activity. There's some really nice work done on referred pain in females, and that's another study that's worth looking at through Google Scholar, or obviously email me for it. If they've looked at a group of asymptomatic females, did internal vaginal palpation, looked at a group of pelvic pain female patients. In the female pelvic pain patients, there was referral patterns of pain. In the asymptomatic, there wasn't. Now, that work has not been done in males, but that's what you see clinically. So when we teach people how to do this on a course, you don't when you do rectal internal male palpation, you're not getting all this pain referral. When you do it on patients, you are. There is Debbie Cohen is a very eminent USA pelvic health physio in California, and Debbie's article is on Moodle, and I would really recommend reading Debbie's article. It's also got a lot of musculoskeletal content. So we know that there are pain referral patterns in female pelvic pain. It's also thought to be a somatovisceral viscerosomatic mechanism, whereby you get maybe someone has an existing bladder, urethral, maybe rectal condition, because you're getting afferent stimulation. in that dorsal horn you get kind of neuroplastic changes crossover, which then leads to changes in the somatic tissue, the fascia, the muscular tissue. Or it can go the other way, where you've got maybe a lumbar spine, pelvic girdle, pelvic floor condition, which then leads to a secondary bladder symptoms. And this is what we see in patients. We see a very mixed pattern. We get lots of allodynia. So these patients, when you palpate their abdomen, which you can do, you're a musculoskeletal or sports physio, when you palpate their abdomen, when you palpate that rectus abdominis, it's painful, or there's referred pain, or there's an allodynic response. You palpate their groin adductor group, their pubic symphysis, there is allodynia, hyperalgesia. You get a lot of pelvic floor muscle tenderness, altered function. And this is something we look on ultrasound, on transperineal ultrasound. You get spasm in the puborectalis, which is a part of the pelvic floor muscle, and that leads to a change in the anal rectal angle. And a bit like other muscles, you get decreased mobility. You know, if we get spasm in the erector spinae or dysfunction in the upper traps, that muscle's not going to lengthen, stretch. It's not going to have its normal mechanical qualities. And we see the same internally. So musculoskeletal wise, Peter's work is really important. And if you Google Peter Dornan, he has written a paper on a musculoskeletal approach to male pelvic pain, which is freely available. So what do we look in the sporty patient? So this might be your weekend warrior, maybe more your elite sporting patients. So are they getting, usually male or female, they've got hip, groin, pubic symphysis issues that are not resolving, but someone has picked up, usually their musculoskeletal physio or their sports physio, that they're also getting areas of symptoms elsewhere, especially in that pelvic area, maybe penile, maybe vaginal, maybe vulval, clitoral, perineal, pubal, rectal. They may be getting urinary frequency. In females, they may mention that, well, using a tampon has become very painful. Or they're getting some changes in erectile function. These symptoms in the sporty, active person, they tend to be a lot less severe than the very debilitated pelvic pain patient. And also they're working, or they're active at a higher level of function. So they're not doing running or CrossFit or Pilates, or they might be training a few times a week, or they may be working at a high level of sport. They tend to have a lower level of this cognitive behavioral components. And when we treat these, we probably treat them in combination with their local sports physio or their club physio. Has anyone heard of jelqing? What I would do is, if you put jelqing into Google, see what you come up with. So jelqing is where men, usually younger men, well, not always younger men, but maybe mid to late 30s downwards, but tends to be more the late teens, early 20s. They do very aggressive stretching of the erect penis to make it longer. But that leads to trauma. So they get bruising, inflammation. They start to get marked erectile dysfunction. And what they also get is this hard flaccid syndrome. So this tends to be the younger men, late teens, early mid-20s, late 20s. So they've had maybe some trauma. So that may be sports trauma. We have had people who've had a maybe a blow to the groin, a kick to the groin. It may be that they've been doing a lot of masturbation. It's hard to know what a lot of masturbation is, but it's a lot. So it may be that they're masturbating, multiple times a day, or they're masturbating for 4 or 5 hours. They're masturbating a lot. And social isolation may lead to a higher incidence of heart flaccid. Maybe that they've had some trauma with sexual activity with a partner. There is a marked psychological component. They've seen multiple specialists and they're seeking help from Google. So what do these men get? They get lack of spontaneous erections. They don't get morning erections. They don't get erections when they are maybe stimulated by something that would normally stimulate them, maybe some imagery, some thoughts, their partner. So they get lack of this spontaneous reaction. They get premature ejaculation, hard to get an erection, hard to maintain it, lack of complete erection. And they get, the big thing is they get loss of flaccidity. So when the penis should be flaccid, it isn't. It feels rubbery. It's retracted. It looks different. They may get pelvic pain, but not always. So it can be difficult to ask these questions, but it is powerful when they are asked, and the patient is very relieved that someone's asking them. So for pelvic floor muscle dysfunction, what we're really looking for to really re-emphasize is, are they getting pelvic pain? Are they getting urinary, erectile, bowel symptoms? We've talked through this a bit already, that these patients tend, it's a bit more common. So you're getting patients with low back, hip, pelvic, ask the questions. Because we know from Hodges research, Paul Hodges research, that pelvic floor dysfunction is very common with back pain. And we know in patients with sacroiliac pain or pelvic girdle pain that pelvic floor dysfunction is common. So what do we do with these patients? We do a lot of musculoskeletal assessment. This is going to be me after self-isolation. I'm an optimist. So what do we do with these patients? We do lots of musculoskeletal physio. We do pain provocation tests for the pelvic girdle. So you can do those. They are musculoskeletal tests. And if you Google them, you can, or if you Google or YouTube them, you can refine what they are. We do a lot of pubic symphysis palpation, looking for tenderness and pain. Why is it painful? Well, it's painful because it's a big muscular attachment for the rectus abdominis, for the pelvic floor, for the adductor groups. So I like to equate it to, I like to say to patients, well, if you had a calf problem, it's quite likely your calcaneus or heel bone would be tender or painful. If you had a quadriceps problem, it's quite likely your tibial tuberosity would be painful. So it starts to educate the patient. And for you guys, it might highlight that if that pubic symphysis is very painful, maybe I need to ask more questions and then maybe send them to someone who can really look at this pelvic floor. The active straight leg raise, is it positive? Is it difficult? Is it an effort to do? Is it painful? Is there poor quality? And the patients who've got high levels of pain, it's stopping them getting around, walking, functioning. They would benefit from a pelvic or sacroiliac joint belt in the short term. So this is typically what we give to patients during pregnancy, but it's very good for these patients also in the short term. We do a lot of abdominal soft tissue palpation. So if you press into your rectus abdominis, it's probably feels like a bit of pressure, nothing else. Whereas with these patients, it's painful. They're getting local pain, referred pain. They can get an allodynic hyperalgesic response. And we know that abdominal wall pain is common in women with pelvic pain. And we also see that in the males. And where do you get referral? You tend to get it into the pubic area, perineum, penile, vulval areas. A big part of assessment are the questionnaires. And I've talked about these several times. These are really important. We do a lot of lumbar spine assessment, and that's really looking at probably progressing to see, well, is there any referred pain into that pelvic area? Probably progressing to doing a lot of combined movements, a lot of palpation, maybe palpation in combined position, but it's basic lumbar spine stuff. This is the breakdown of the active straight leg raise, but really I say to patients, is it easy or difficult? If you're doing this for research, obviously it needs to be more objective. We also do a lot of posterior hip palpation. Same again, really looking for patterns of referral. And we look at the hip. You know, we don't probably do as detailed a hip assessment as David would do, but we probably look at range of movement, quadrant, general flexibility control. So what do we do with the pelvic floor? Well, we try and see, well, can they do a fast contraction, a slow contraction? So if you do this now, whether you're in sitting or standing, so what you're going to do is tighten around the back passage, tighten around the front, as if you're stopping yourself from passing urine. So you're going to tighten back and front and lift. So if you're in sitting, you should feel that middle bit almost lift from the chair. So a bit like other skeletal muscles, we have fast and slow twitch fibers. So what we're going to do now is, well, let's do some fast twitch contraction. So I want you to contract fast and hard. And the minute you feel it contracted, just relax. So you're going to contract, let go, contract, let go, contract, let go, contract, let go. See how long it takes you to do 10. Someone asymptomatic, they'll probably do 10 in less than 10 seconds. The pelvic pain patient will probably be able to do 2 or 3 and then it'll feel they can't relax. The patient who's weaker, they probably won't be able to do 10, or it'll take them a lot longer. With the slow contractions, what we're going to do now is contract, but contract at about 50% of intensity. So contract and let go. So you're going to contract back and front about 50% and hold. So someone who's asymptomatic probably could hold for maybe 40-50 seconds. The pelvic pain patient will struggle to hold because it'll feel like everything's going to tighten up. And the patient who's weak may have very low endurance. They might hold for maybe 5-10 seconds, but then it will tire. So we're trying to see what, when they do these, and we are, in a way, we're dependent on what they feel, unless we're looking at it with ultrasound, which we do, unless we're palpating them internally, which we do. So is it easy to do? Is it difficult? Is it painful? Where is it painful? So it might be that they're getting coccyx pain. Coccyx pain is very common with pelvic floor dysfunction. It may be that they feel it's tiring. They may feel that they can contract it but can't relax it. So musculoskeletal physiotherapy uses ultrasound a lot, as does pelvic health. So we would put a probe, lower abdomen, see the bladder, and we can, as the base of the bladder lifts, we can see is that muscle contracting or relaxing? And then a progression of that is where you put an ultrasound probe on the perineum and see what's happening in detail inside. But I think really a starting point is stage 1. So this is a typical trans-abdominal image, and we're looking when you do a nice contraction. This elevates, base elevates, relaxing, comes down, elevates, relaxes. And that's quite a nice visual for the patients also. We also want to see, well, are there any areas of muscle hypersensitivity? Any allodynia, any hyperalgesia? A bit like we would have called trigger points in the past. So are there any abdominal trigger points? Are there any posterior hip trigger points? We also palpate a lot into the adductor longus, the adductor group, anterior aspect of the hip, lumbar spine. We use a lot of internal ones, but the good thing is you can use the wand outside as well. So what do we do for treatment? We do a lot of manual therapy, depending on what we find. Into that lumbar spine, also thoracic spine, ribs are important, hip, pelvis. We want them to really relax a little bit. We want to relax those muscles if they're overactive. So this is where we get people doing a lot of abdominal breathing, a lot of belly breathing, in lying initially, then sitting, standing. So the reason we get them doing a lot of abdominal breathing is when you breathe in to the abdomen. So if you put one hand in your abdomen, one hand in your chest, trying to breathe into that abdomen. So the diaphragm descends, the pelvic floor descends. So you're just getting some movement into those muscles. A bit like if your hamstrings were tight and active, maybe overactive, you'd do hip and knee movement. And Carl Monaghan is a friend and colleague of mine, and Carl has some really nice exercises for pelvic floor relaxation. So let's see if we can find those. So what you could do maybe is Google Carl Monaghan. It's the Pelvic Pain Clinic, and you'll find Carl's work. It's very good. We also want to get these male and female, either pelvic girdle, pelvic pain patients. We want to get them back to exercise. But you guys are the experts at that. Graded return, a bit like you would take someone who's got a knee ankle problem back to running, a bit like you would take a shoulder pain patient back to playing sport. So if we might get them doing walk run first, couch to 5, maybe some weight bearing exercise, a bit of graded exposure, a bit of pacing. So just to re-emphasize, there's a lot of pelvic girdle assessment and treatment, a lot of soft tissue assessment and treatment, a lot of lumbar spine, both differential testing and treatment. Neural and neurodynamic, that really comes in when they're presenting, a bit like you will have done with OOZA, when they're presenting with like a neurogenic pain pattern, pins and needles, numbness, maybe referred neurogenic pain. They're getting symptoms of kind of using descriptives that they've got a lower limb neurodynamic component. And with the hip, I would kind of signpost you back to David's work that you did 2 weeks ago. So I would like to say a big thank you for listening. I would just like to highlight, for those of you who are looking at this doing the Masters in Coventry, thank you for listening. And on Moodle, you will find some of the key articles. You'll also find some links to the MAP project. which is the multidisciplinary approach to pelvic pain, which is a big centre of research for pelvic pain. And you will also find some other pelvic girdle resources. And wishing you every success with your masters, and hopefully when we eventually get back to normality, we will meet up in person. And any queries, please email. Thank you very much for listening, and stay safe.